Good morning, good afternoon, good evening, everyone. My name is Jean-Charles Prézère. I'm in Brussels, Belgium. I'm very thankful to Nestlé for having organized this important event, this webinar on enteral nutrition in focus, on an emerging topic, which is the post-acute optimal nutrition, which is definitely an emerging topic, probably under recognized until now. And so we will address the issues of what happens in terms of nutritional care after acute illness. Feel free to ask questions in the chat. We will address and discuss and then try to answer the questions after the two talks. And I will no longer wait to introduce my good friend Art van Zanten from Ede in the Netherlands. So Art van Zanten is intensivist, he's an expert in nutrition, he's professor of nutrition in the University of Wageningen, if I'm right. It's also a very active investigator, an excellent lecturer and teacher. And it's my pleasure to introduce his talk entitled Optimizing Post-ICU Enteral Nutrition Interventions, Strategies for Maximizing Recovery. Please, Art, thank you for being there and for addressing this important topic.
Well, thank you very much, Jean-Charles, for the kind introduction and everybody for attending this exciting webinar. I will address this topic, but I will start a little bit earlier in the ICU to let you know why I think that post-ICU nutrition is so important. So here you see my disclosures. I've given lectures for many companies involved in the field of clinical nutrition, and I'm also involved in sepsis and especially in nutrition in national and international bodies involved in nutrition optimization. So we all want to improve the outcome of our patients in the ICU. But to do that and to have an optimal functional outcome with a good quality of life for our patients, we have to follow these patients through the various stages of their disease. It's a patient journey. And of course, the final outcome of the patient is very much dependent on the premorbid condition. So if you are frail before ICU patients, of course, your outcomes will be less good than when you are in optimal health condition. And of course, also the acuity of your acute illness is important. Do you have like a minor problem to be admitted to the ICU, or do you have a severe illness like sepsis syndrome or so with multiple organ dysfunction syndrome? So your prognosis and outcome will be different. And of course, then during ICU stay, we can do all kind of treatments and put patients on all kind of devices that can also introduce harm. And with respect to nutrition therapy, it's complex because feeding the patients in the ICU is a little bit different compared to during health. Because we have this complex situation of having inflammation in all ICU patients actually, and most of them have severe insulin resistance. I come back to catabolism and anabolism later, and they have variations in energy expenditure. Sometimes when you use enteral nutrition, the GI tract is also a target of the disease. And you can have enhanced oxidative stress and problems with autophagy, these cleaning mechanisms of cells. Well, to summarize this, it's complex to feed our patients in the ICU. And then the patients, when they survive their stay in the ICU, have to go into the recovery phase. And then I think nutrition therapy is essential. And we start rehabilitation, exercising the patients, and then we have the final outcome. Is the patient in a good condition? Is the muscle function okay? Can the patient be discharged home or should be going to a rehab center or a nursing home? So that's essential. But you can see in this slide that the final outcome is, due to various factors. And of course, we have to optimize all those factors during ICU stay and also during recovery. Now, first of all, how you are admitted to the ICU is important for your final outcome. We already knew that those patients with a high lean body mass or a high BMI actually had better survival. But we now know it's not actually the body weight that's important, but it's the muscle mass. So if you dissect the body composition into the components, you see that the survival is more associated to the lean body mass or the lean muscle mass than to other body components. So I think it's important to notice that how many muscles you bring to the ICU is important for your final outcome. And this obesity paradox that patients with a high body mass index have a better survival chance is probably due to having a better muscle mass. And then it's also important to recognize that obese patients can have either a low or high muscle mass. So when you are more the type of bodybuilder, you will have more muscles. And when you have sarcopenic obesity, it's more fat mass. So that's important to know that the body composition is important for the final outcome of your patient. Then we know that in the early phase of critical illness, we should not aim for the full energy target we measure by indirect calorimetry. So in the first week, also in the Aspen guidelines, we recommend to give about 70 to 80% of the target to prevent overfeeding of our patients. And we know that overfeeding is associated with worse outcome, more morbidity, more organ failure, more infections, but also an increased risk of mortality. So overfeeding in the early phase of critical illness should be prevented. And this is probably one of the reasons, and this is also a paper by the chair of this session, showing that in the early phase of critical illness, there is a lot of endogenous energy production. There is breakdown of body stores, especially glycogen from the liver, leading to a lot of endogenous energy production. And when you give the full dose of your enteral or parenteral feeding on top of this, depicted in this slide, so when the full dose is 1500 kcals per day, and you give it on top of the endogenous production in the first few days, you see there will be overfeeding for this patient. So the best is to gradually increase your energy intake over days. And what we recommend also in the guidelines is to do indirect calorimetry around day 4 and then see what is the individual target for your patients. And of course, you will check daily phosphate to detect refeeding syndrome. And this is the way we think we have to move on with energy targets over time now. Now let's move a little bit to the muscles. That's important for the protein dosing of our patients. So patients lose a lot of muscles during ICU stay due to immobilization and also due to inflammation. So they have a catabolic state, they break down the muscles, and there can be a huge loss of muscle mass. So if we look at the metabolic situation of patients in the ICU, it's different than in during health. So in health, we have this anabolic catabolic pendulum. So when you start eating, glucose levels go up, insulin levels go up, and you will store your nutrients into body tissues. So glucose will be stored in glycogen, for instance, in the liver, and free fatty acids, and also glucose will be sent to the fat mass, and the amino acids from proteins will be stored into the muscle proteins, so will be in the muscles. And when you starve yourself, you don't eat for a longer time, you go into a catabolic state, and you can regain these stored energy stores and these macronutrients from body stores. But during critical illness, there is a persistent catabolic state, despite the fact that we give nutrition or the anabolic insulin hormone that's necessary in the majority of our ICU patients. So it's different. Patients are in a persistent catabolic state. They break down their body stores. And this is one of the reasons that in the early phase, also this glycogen breakdown is, continuing, although we give insulin. This all leads to huge muscle mass loss. And this is work by Zuden Puttichering, showing with ultrasound of the upper leg that in patients during the first 10 days of ICU stay, you can lose up to 25% of your muscle mass when you have multiple organ dysfunction syndrome, and that translates into a muscle mass loss of about a kilogram per day. So that's huge, and it takes a long time to regain such a muscle mass loss. If you go to the gym, you do exercising, it will take a lot of time to regain 1 kilogram of muscle mass by exercising. Now, one of the ideas is that we should provide more proteins in the ICU. And recently there was this meta-analysis performed by the group of Darren Hyland from Canada, showing that when you summarize all the studies that have been performed, almost half a gram per kg per day more of protein delivery with a similar energy delivery in study arms in this meta-analysis was not associated with improved outcomes when delivered this high protein intake within 3 days of ICU admission up to 28 days in the ICU. So these were all smaller studies and showed that there was no effect of high protein intake on mortality, duration of ventilation, hospital lengths of stay, ICU lengths of stay, or infectious complications. Then they recently published the data on a pragmatic study, the EFFORT trial, with very high dosages. So they aimed for a prescribed dose of 2.2 grams per kg per day and a usual dose of 1.2. Well, they achieved a little bit lower, 1.6 grams versus 0.9 grams per day, and the energy intake was about the same. They had a very aggressive build of protein, so most of the patients in the high protein group were above 1.7 gram per kilogram body weight per day in the high protein arm. And what they found in the study, there was no effect on the primary endpoint, the time to discharge alive from the hospital by treatment group at day 60. So the high protein intake during ICU stay did not translate in this in an approved outcome reflected by this primary endpoint. But they found in the subgroup analysis that in patients that were treated in the high protein dose group with AKI, so acute kidney injury stage 1 to 3, and high SOFA score, so more sick patients, they had an increased risk of mortality at 60 days. So it seemed that many patients in these groups were not able to handle a high protein dose as reflected by these study groups. Now, what could be the reason for that? Now, one of the reasons could be, and this is a study we performed during the COVID pandemic among 150 COVID-19 patients using bioelectric impedance assessment. That's a technique using, well, electricity, small currents that go to the body to measure body composition. And we looked at the lean body mass, if you wish, the muscle mass of the patients with COVID-19. And here you see the patients. And it's not a rocket science, but you see in blue that the males have a higher lean body mass than the females in this study. And still, we don't, in most studies or in most prescriptions, we do not make a difference in gender or in sex for prescribing proteins. Moreover, if you take two males with the total body weight of 100 kilograms, you can see you can have a lean body mass slightly over 50 kilograms, but it can also be 80 kilograms. So there can be a difference in muscle mass in a man with a total body weight of 100 kilo of 30 kilograms. So in one patient, the amount of proteins you give can be much too high, and in other patients, it can be a too low dose for them to not lose the muscle mass. So I think we have to more individualize the protein dosing for patients in the ICU. And now recently, there are more publications about the urea to creatinine ratio, the UCR, reflecting the metabolic fate of proteins. So when you give proteins to the patient, they are digested and they're absorbed. And we know that the absorption in ICU patients is rather okay. So the proteins are absorbed and it will be, metabolized to amino acids and go to the muscles. And in this slide, this is a single patient that was in our ICU for about 75 days, so a long duration. And in the upper panel in green, you see the creatinine levels over time. And you see they slowly go down, reflecting the muscle mass. There is loss of muscle mass, and so you will see gradually a reduction in creatinine levels. But you see in the lower panel, the creatinine, the UCR, so the ratio of creatinine of urea over creatinine, is very variable over time. And I plotted also the CRP levels in these patients. So this patient had like 3 infectious episodes. First one was the admission pneumonia. Second, there was a line sepsis, so a bloodstream infection. And finally, there was a second ventilator-associated pneumonia. And every time you see after this infection, you see a period of high urea to creatinine ratio, suggesting that the proteins that were exactly the same in this patient, the patient received a similar protein dose all the time and had no gastrointestinal problems, you can see that the UCR goes up, suggesting that not all the proteins we give to the patients can be used for muscle protein synthesis. In other words, there are episodes of metabolic resistance in muscle, so that you cannot use the feeding we give to the patients or the proteins. So I think it's all a matter of timing and dosing. So energy and protein administration is only helpful when it can be used in metabolic or anabolic pathways. And overloading your metabolic systems may lead to side effects, such in the early phase when you give too much of the energy, it will lead to hypoglycemia. You can suppress autophagy. We know from work by Zuden Puttigieri also that the patients in the first week with the highest proteins intake had the highest muscle wasting and breakdown of proteins from muscle stores. You can also induce a pro-oxidant condition, so more reactive oxygen species. And of course, we know also high energy intake is associated with the induction of refeeding syndrome. In that case, you have to restrict the caloric intake in your phase. Now, with Paul Wischmeyer and Elisabeth de Waele, I published this paper a few years ago suggesting that we have to have a more gradual approach to feeding in the ICU. So in the first few days, you have to have a stepwise increase in energy and proteins, and then you have to meet the target around day 4. And in the late phase of critical illness in the ICU or after discharge to general wards, we have to increase the intake of both energy and proteins, maybe 125% of your equations or measurement. We recently published a paper of one of my PhD students confirming that, well, energy expenditure in general wards is about 25 to 30% higher than in the ICU. And after hospital discharge, during the rehabilitation phase, this has to be increased further because patients start exercising, and we also have more anabolic possibilities, and the patient is able to handle this substrate. So in the August edition of Current Opinion in Critical Care, that was fully dedicated to metabolic support and nutrition, I made this graph in the editorial. So what we do now many times, we have a one-size-fits-all strategy. So we prescribe energy based on kcals per kilogram body weight or ideal body weight. We use predictive equations. We use protein dosing in grams per kilogram body weight per day. But maybe we have to go to more phenotyping, so to look at the lean body mass. So what is the body composition? Maybe we should use indirect calorimetry to know exactly what is the need of our patients. And we also have to adjust for non-intentional calories from propofol, glucose, or citrate. But the next step would be endotyping to know what is the metabolic fate of all the nutrients we give. And then we can maybe use the urea to creatinine ratio. we have to look into like RQ, insulin demand. For energy, it's more complex. But that's the next step to go to personalized feeding in the patients. And this is all due to the fact that they have prolonged catabolic situation. So the next step is post-ICU nutrition, and that's the window of opportunity. But there we have a lot of problems. Patients can have poor appetite, early satiety, some nausea or vomiting, change of taste and smell, what happened with COVID-19. They can have like dysphagia, ICU-acquired weakness. Sometimes they are depressed or have post-traumatic stress disorders. Sometimes the hospital system is not very well matched or adapted to the needs of the patients, and sometimes even the food quality is suboptimal. And this is work by Emma Ridley from Australia, showing that if you have only oral intake in the post-ICU situation in general wards, that the caloric intake is about 50% of the target, and the protein intake is about 40% of the target. And only with the addition of oral nutritional supplements or enteral nutrition, you can meet the needs of these patients. Now, in our hospital, we have more like a room service system. So you can call to a room, to a call center, and then you can order from this menu, and it will be freshly prepared to your room within 30 minutes. So it's like a hotel. But the advantage of this system is that we exactly know what a patient has ordered. So exactly for breakfast, lunch, or dinner, we know what are the calories, what are the proteins, and we know exactly what is ordered. But what is ordered is not eaten. So we have this digital food chart, and it has to be scored by the food assistants and the nurses, and they have to estimate what is the intake. So what is eaten from what was ordered from the oral intake that was sent to the room of this patient. And sometimes we see that patients do not eat what they have ordered. And we did this Prospect 1 study. In this study, we measured actually what was the actual intake from what was ordered by the patient. We used these cameras with change, because otherwise they were stolen by the patients and the families. And sometimes also the food was taken home with families, not eaten by the patient. So it's very important to monitor the actual intake of the patient. And what we found was really striking, that before enteral nutrition, so tube feeding was stopped, it was above the target. And the day after, the energy intake dropped by 44% to low values. And the same holds for proteins. So there was an adequate protein intake of 111% of target. And the moment you take out the feeding tube, it dropped by 50%. So this leads to the conclusion of this Prospect 1 study that was published last year, that we should probably continue the tube feeding a little bit longer in the post-ICU phase, and we should monitor the intake. We did a study, the Valley Food study, to see whether food assistants and nurses are able to estimate the intake of her patients. And we weighed the food using scales, and then we measured what they scored. And we found that frequently the intake of patients is overestimated. However, it was less than 10%. So in general, you can say that nurses and food assistants can do a very well estimation of the intake of our patients. Now, the next step is to improve this performance, and that's what we're now doing in the Prospect 2 study. We made this protocol. So when the patient is 100% tube feeding in the general ward, we bring this down when the oral intake is improving. So then we taper the tube feeding in steps of 20, 40, 60%, but only when the patient has shown to be over 110% of proven intake. So we will not lower it in the hope that the patient will start eating better, because this is a misconception that you have to reduce tube feeding to induce like hunger sensations in the patient or so. That's a misconception. And in the final steps, we introduce oral nutritional supplements. And if you, of course, when the intake is very good, you can go faster. And when it's not good, you go back to the previous step. And only after 24 hours of proven high intake, we take out the feeding tube. And if necessary, we will reinsert the feeding tube. And then we will taper the oral nutritional supplements, and then the patient is on full feeding. And this is what we now test in the Prospect 2 study. There are more studies ongoing. The intent trial on energy during whole hospital stay from Australia. We do the Prospect 2 study I've just shown you. And the Confucius trial, that's a randomized control trial to show whether high protein intake versus carbohydrate in supplements improves functional outcomes. So to summarize all this information, I think we have to focus on tailored nutrition during the patient journey. In ICU, we have to do no harm. We have to prevent overfeeding and to prevent early very high protein intake, especially in patients with high SOFA scores and acute kidney injury. And I think the window of opportunity is later during ICU stay and especially post-ICU discharge. But then we have a problem because there is lack of knowledge of nutrition among ward healthcare professionals. The dietetic services are not always available, maybe only during office hours and not in the weekends. You have to be aware of the fact that prescribed is not ordered, and what is ordered is not always eaten. So you have to monitor the intake. And feeding tubes are frequently removed too early. So we need a multifaceted, interdisciplinary approach in the general wards with nurses, dietitians, the doctors of the general wards. But maybe we as ICU professionals should create this awareness that post-ICU nutrition is really a challenge and a problem, and we can do much better here. So with that, I'd like to conclude, and I'd like to give back the stage to Professor Jean-Charles Preiser. Thank you for your attention.
Thank you very much, Arthur. It was very clear and convincing. So we will keep the discussion for after my talk, which will start now. If Daniela can please share her screen. So the title of my talk is Building a Culture of Care, Increasing Awareness on Enteral Nutrition Among the Care Chain. Next slide. Next slide, please. Okay. After COVID-19, we got a new pandemic, maybe. Next slide. It's ICU acquired malnutrition. In fact, as Professor Van Zanten showed us, next slide, we got a lot of reasons to get malnourished, to become malnourished during a stay in the ICU. This is a slide from the team of Leslie Moisey and John Drover in Canada, just showing in summary the premorbid condition and the critical illness by itself, or the treatment needed to keep the patients alive could contribute to the development of malnutrition, either the stress, the inflammatory response itself, or medications, or also the immobilization, or iatrogenic undernutrition at the late stage of the ICU stay. All these factors can contribute to the decrease in lean body mass and physical function, and typically the incidence of malnutrition is very high after a prolonged ICU stay. This was, next slide, this was very convincingly shown by a team from Paris, showing that during the COVID-19 pandemic, you can see on the first column, these are the blue portion is the proportion of patients without malnutrition, so about 80%. At the time of ICU discharge, only 20% of the patients are not malnourished. So meaning that 60% of the patients did acquire malnutrition in the ICU using the GLIM criteria. And this undernutrition or malnutrition persisted over time until 3 months. There were about 30% of patients non-malnourished after 3 months. It means that it takes a very long time to recover from the ICU acquired malnutrition. Next slide. We looked in our hospital of what happened in about 15 individual ICU patients hospitalized for COVID-19. We were quite used and successful in starting enteral nutrition, parenteral in one patient, or the combination of oral and enteral after a few days. So these are the individual patients. Next slide. But we saw that indeed the amount of calories provided was very, very small, about 20%, 20 kilocal per kilogram per day until about 1 month after ICU, after admission. So we were quite not successful in increasing the amount of energy and also proteins probably. Next slide. When we looked with next slide, please. When we looked with colleagues in Liège, in Belgium, at the amount of calories and proteins provided by enteral, oral, and parenteral feeding, we could indeed see that the oral feeding alone was associated with a very low iatrogenic undernutrition. We were able to provide about 5 to 10 kilocalories per kilogram per day for weeks. So the patients are underfed, in fact, receive low amounts of energy and proteins during an acute illness. This was also shown, next slide, in a very large survey of more than 100,000 patients, showing that patients after an ICU stay, received enteral and parenteral nutrition more often than patients who didn't stay in the ICU. But still, the undernutrition was found in both subgroups of patients, regardless of a stay in the ICU or not. Next slide. The consequences of this undernutrition could be muscular weakness. As we have seen, the hand grip test strength was tested in our cohort of 15 COVID-19 patients, and it was well below the expected value for the age and gender of the patients in all the 15 patients when they were prospectively assessed. So this is, next slide, this is probably a component of the post-ICU syndrome. You may know about this. So the post-ICU syndrome was described 50 years ago, but there was an official definition in 2012 by Dale Needham and the team of American investigators, with a combination of physical dysfunction, mental health dysfunction, and cognitive problems and dysfunctions. So the physical component of the post-ICU syndrome is probably resulting, at least in part, from the lack of energy and proteins during the late phase of the ICU stay. Next slide. Acht van Zanten and his colleagues published also a nice figure showing that patients could be assessed, and even after 5 years, the 6-minute walk test, and also after 1 year in COVID-19 patients of the lower or the bottom part of this graph have a decreased hand grip strength, just showing that muscle weakness lasts for long after an ICU stay. So we probably need to start, next slide, nutritional rehabilitation in the ICU to avoid this type of character with a very with crazy people with having a loss of muscle mass, like in this picture inspired by Kafka. So next slide. We know, and this is a slide from Zudin Putucciari, that the muscle mass drops very rapidly and it takes a very long time to recover as a result of the balance or the imbalance between muscle protein breakdown and muscle synthesis. So it takes a long time to recover. We need to, next slide, to have a collaboration between the acute caregiver, the acute physicians, and dietitians, etc., that is working during the acute phase, and those, next slide, caring for the patients, like this intellectual internist during the chronic phase. when the patient is discharged from the ICU. Next slide, we need some continuity between the ICU, the ward, and the post-hospital discharge. Next slide. Now, if we look at the reasons why patients do not receive the prescribed amount of enteral feeding in the ICU. This was a survey in France about 20 years ago, but I suspect that this is still true. The airway management is an issue, digestive intolerance, diagnostic procedures with interruption of enteral feeding, and mechanical problems that can be summarized into high gastric residual volume, or the fear for pulmonary aspiration, or diarrhea, constipation, gut ischemia, can all be quoted to justify the interruption or decrease in enteral feeding, favoring when occurring at a late stage the ICU acquired weakness. Next slide. After ICU, we also know that the patient, the food intake is low for several reasons, including reasons related to the patients themselves, or also to reasons related to clinicians or to the system. Among the reasons related to the patient itself, the appetite, the taste can be changed. We saw that quite often after the COVID pandemics. Also, there are problems with the gastrointestinal dysmotility, swallowing problems, especially when patients have been intubated. Physical function can be altered, or also psychosocial factor can be advocated. In terms of clinicians, we need to increase the awareness. There is a lack of documentation of the amount of food which was eaten by the patients. Clearly, there is a lack of attention on this. Also, the feeding tube is often, as Arthur showed us very elegantly, the feeding tube is removed too early. And in fact, feeding is, or the food is not a priority in the hospitals, and this may be also related to the system. You know that the financial burden is really often advocated to get low price food. We are not all in working in aid where the patients can be like in the hotel. So next slide is I think it's a central slide. Who is guilty for this? Next slide. The attending physician. The nurse interrupts enteral feeding. The nursing aide lacks of attention toward meals. The dietitian is not always there and does not always know the ICU procedure. Next, the physiotherapist interrupts enteral feeding to extubate the patient or for a trial of spontaneous breathing. The speech therapist, which could be needed to take care of the swallowing disorder of the patient, is not always present and available. And the family is fearing, the family is impressed by the devices, by the monitoring systems, by the noise, etc., and doesn't like to give food to the patient. So we definitely, next slide, we need and also organizational factor can be also advocated, the transfer for an exam of procedure or the lack of protocol. So next slide, we need to adapt the guidelines to the local routines. So guidelines are available. Sometimes they are contradictory. Sometimes they can be difficult to apply at bedside. You know, the ESPEN guidelines and also the ASPEN, the American guidelines, with 95 recommendations. 6 were updated recently. So we need to adapt to translate the guidelines into our current environment. Next slide. There is a need to adapt to the local routines to avoid to be lost in translation. We need to adapt the general guidelines to the type of tubes, to the formulas we have at hand. You can click, please. Okay, the type of patients and the local habits. Next slide. Protocols for enteral nutrition in ICU are really needed because of the interest of early enteral nutrition, because of the frequent gastrointestinal dysfunction and the high rate of complications. And we should also anticipate frequently asked questions. Next slide, such as diarrhea. What do I do in case of diarrhea? In case of ileus, what which are the initial settings, how do I check the position of the feeding tube. These very practical aspects must be anticipated to answer the questions of the nurse who is on duty Saturday night. We may like to use acronyms, next slide, such as FAST-UG from Jean-Louis Vincent. Feeding, the F of FAST-UG is feeding and fluids, but feeding is of course the most important. Next slide. There is another acronym such as SPICE for the quality of care, just to check the SPICE, swallowing disorders, also the physical ability of the patients, the involvement of dietitians, the clinical evaluation. These are all addressed by this SPICE acronym. You may have a look at this paper published in Nutrients in 2020. Next slide. You also need to be there assertive, smiling and available. These two ladies are two dietitians, Gabby and Marie-Eve. They are every day on the weekdays in the ICU, and the presence of the dietitians, they know each patient, but it helps to improve the quality and the involvement of all nurses and physicians. They think about this, and also dietitians needs to be, next slide, needs to be the role of the dietitian needs to be emphasized. And Gabby gave a very nice talk on the role of the dietitian in the ICU during a Congress of Nurses, of intensive care nurses. Next slide. So if we want to change something, we need to define the outcome to be improved, to identify the room for the improvement, and then to change the practice and check that the improvement is indeed, the expected improvement is indeed happening. If not, you should change again. And the nurses must be involved in this. Next slide. So this is Mathieu, a nurse from our ICU. He just reported in a congress that just having a monitoring of gastric residual volume, a systematic monitoring of gastric residual volume at this time was associated with an improvement in practice. Next slide. So he showed that the time to achieve the target rate was much smaller, was much shorter when gastric residual volume was monitored. And next slide, also that the difference between the target energy and the actual intake was really improved just by a small change in practice. They also are, we are also encouraged to participate into general surveys such as Nutrition Day. Next slide. So the Nutrition Day, the Belgian contribution to Nutrition Day is very impressive because of the involvement of the Ministry of Health, and the Nutrition Day helps to understand that. Next slide. In fact, the intakes are not calculated as a function of the weight. Next slide. You can see on this slide that these are different levels of BMI, and you can see that the obese patients on the right panel are those who receive the less calories because the BMI, the weight, is not taken into account into the prescription of enteral nutrition. Next slide. We also participated into this study, the France study in France and Belgium, and this nice, just observational study. Next slide. Showed that no nutrition during the early phase of the ICU stay was associated with a better outcome in terms of day 28 mortality than early nutrition. So we can wait, there is no emergency, and this is quite relevant for the need of appropriate nutrition, which is definitely more related to the late phase than the early phase. Next slide. And this was also confirmed in several, next slide, please. This was also confirmed. Oh, if you can switch to the next slide, please. Okay, so and the next again, this was also confirmed in this large French study, which the Nutrirat 3, which showed that patients receiving 6 kilocalories per kilogram per day instead of 25 and 0.4 gram per kilogram per day of proteins instead of 1, had a better outcome in terms of readiness to be discharged from the ICU. Next slide. And also there was a strong trend to a better vital outcome in those patients who received less calories and less proteins during the early phase. This can sounds like counterintuitive, but probably that the early days of ICU, during the early days of the ICU stay, the patients are not able to use appropriately the nutrients that we provide. So we should probably ramp up progressively according to the tolerance of the patients. And the last slide, next one, please. And the last one. So the last now is a few expert tips. Just to summarize, we need to involve each category of healthcare professional, the nurse, the dietitian, the physiotherapist, the physicians. We need a systematic policy adapted to local routines, including frequently asked questions. We need to use, or we may like to use, understandable acronyms. We need to be there, assertive, smiling, and available in case of questions. The nurse, the dietitians know that I am always available, and to participate to surveys and give a feedback to the team. We need also to involve the healthcare professionals into clinical research and to try to get them into congresses to present the data, and to pay attention, of course, to the continuity of care when the patients are leaving the ICU. With that, I close, and I will be happy to share the questions with you. Thank you for the questions we received. So I can start with maybe using supporting the questions from Roland Thibault, especially the ones addressed to Art van Zanten regarding the variation in lean body mass in COVID-19 patients. Could these be related to variations in total body water, and which equations did you use? And I think that in the mind of Roland, the phase angle should not be that far away from the question. Please, Art.
Yeah, well, thank you, Ronan and Jean-Charles, for this excellent question. So what we did, because bioelectrical impedance assessment has an enemy, there is a problem. When there is water excess, the system can overestimate the lean body mass or the muscle mass. So when there is increased extracellular water, it will be regarded as muscle mass. But there is a normal ratio, and we use a multi-frequency sequencer in the BIA, and this device is able to dissect intracellular from extracellular water, and there is a normal ratio of 0.38 of extracellular to intracellular water. So when this ratio is increased, we have recalculated the lean body mass. So we have adjusted for the excess in water. So this is the best way to do this. So the variations in lean body mass depicted in the slide I showed are not due to water differences, but are adjusted for the excess of extracellular water. So I think there are real differences in lean body mass if you compare different persons with the same total body weight, as we can understand. Because
And a related question was asked by Giuliana Belluccini. Is it useful to use the phase angle value as a monitoring parameter in the loss of muscle mass?
Well, that's a difficult question, because the phase angle, well, is a very difficult physical, parameter. And when it's low, it has a predictive value. So when it's low, it predicts a high risk of mortality. And also in patients with malnutrition and poor condition, it can be lower. But there is a difference between males and females. And what we also see that in patients, when the phase angle is improving, is going up, that's a signal of improvement of the general condition. So there is a higher likelihood of survival in patients with an increasing phase angle. in contrast to the patients where it stays low or even when it's declining. So we also measure phase angle, and we saw a real strong association in COVID-19 patients with a low phase angle and high mortality. So that's absolutely true. But I think it's not very helpful to know exactly what is the muscle mass. So it's not a marker of body composition. It's more a marker of muscle or cellular membrane health. So it's a little bit more difficult to interpret. But we know that a low phase angle also has been shown to be associated with 1 year mortality. So it's both short-term ICU and in-hospital mortality, but also 1 year mortality. So it's an interesting
Yeah.
value.
I think that an unanswered question is whether the monitoring of phase angle every week or every 2 weeks can help to guide the physical rehabilitation together with the nutritional intakes. I think that needs to be addressed
Yeah,
by studies.
yeah. I think it's too early to say that we have to do this now. We monitor the muscle mass by BIA every 3 days. So we measure BIA every 3 days, and we do indirect calorimetry. And I noticed there was also another
Yeah,
question by
ICU.
Lotte Buyle on whether we continue indirect calorimetry in general wards. And that was published recently by Hanneke Monen, one of my PhD candidates. And that's what we try to do. But there is a challenge. Because in ICU, during invasive ventilation, we had like a 59 or 95, 96% of the patients on ventilation had their measurements. So it was feasible to do it because it's not so difficult to connect the indirect calorimetry device into the ventilation system. But in general wards, you have the problem that the patients have to be put underneath a canopy or a hood. And another problem there is oxygen. So when you give oxygen therapy to the patients, you cannot use this technique. So we found that it's about only in 25% of the patients it was possible. And some patients also with post-traumatic stress disorder and depression, they have problems with claustrophobia of the hood of the canopy. So in general wards, it's a real challenge to continue measuring. We try to do it, but it's very difficult. In ICU, we have a very high success rate of measuring.
If I may add just that, indirect calorimetry helps to measure the resting energy expenditure or the energy expenditure, but this should be the interpretation of energy expenditure is different when you are at the beginning of the disease. It's probably the maximal value. You should never go higher than this, while during the recovery phase, this is the minimal value that you need to achieve. So the difference in the interpretation is really huge between the early and the late phase. But still, it makes sense to use indirect calorimetry, especially in the post-ICU when the patients get more complications. You see that the muscle do not increase, etc. You may ask yourself whether the energy intakes are high enough. That these are, of course, there is a lot of unanswered questions and issues. I just take the other question from Roland Thibault. To assess food intake, you could also simply use semi-quantitative methods, such as proposed by the Nutrition Day or visual analog scale, or a SEFI, simple evaluation of food intake. Since artificial intelligence needs to be improved because are not enough precise. Thank you. What do you think?
Yeah, of course, for this study, we want to do this very precise and to know exactly what was the intake, also the macronutrients, what about the proteins. And so we want to know on a daily basis, because the study by Emma Ridley was done like, I think 2 times per week. They measured, we measured every day. So it was a lot of work to do this, but we wanted to know it very exactly. But I think there are other techniques that are more simple, and this global assessment by nurses or food assistants is rather okay. It's slightly overestimating the food intake, but in general, it was very good. So you can just look at the plate of your patient, the food tray, and say, well, this was 50% the meat, and this was the vegetables were 25%. That seems to be rather okay compared to what was actually eaten by exact weight, what we had as the gold standard. So I think you can make in daily practice, you can make it much more simple, but this, of course, was a scientific experiment.
I think also that the having just a sheet that the nursing or the nurse or the nursing aide need to fill every day, it increases the awareness towards nutrition, and just having the sheet to fill, and
Yeah.
this is a way to improve the education and to increase the awareness. There is a last question. Can you please explain that to reduce tube feeding, the total intake higher than
Yeah.
110%? Can you answer that?
Yeah, I understand. This is this Prospect 2 study protocol.
Yeah, yeah.
We had a lot of discussions also with the dietitians how to do this, because when you say, well, I accept 80%, and then I start reducing, and the next day you also accept 80%, so then you end up with a deficit that is progressively ongoing. So we want to be sure, and this is a really challenging protocol. We only want to reduce tube feeding when the intake of the combination of oral and tube feeding is above 110%, to be very sure not to reduce it too early. So that's is a very different strategy. I know that some dietitians say, well, we reduce the tube feeding by 50% and we motivate the patients to eat orally. But then if you look carefully in these kind of studies like we did and others, then the intake is much too low. So this is a way to do it differently. Only reduce when you show that the patient has sufficient oral intake.
Okay. Very good. Thank you very much. I think and I see that the time in running. We could keep going and discussing overnight if we want, but I think that this slot is really we are getting to the end of this nice webinar. Thank you very much for this first to Nestle and for Daniela Padilla, especially for having organized this. The audience also for being there, more than 200 viewers. Please be informed that we will get a certificate and a feedback form after the event, and I hope that we will be aware of the results of the feedback. So thanks again for all of you. Thanks, Art, for this excellent presentation as always, and thanks also for the discussion. And we are of course available if needed. And finally, thanks again to Nestle Health Science, and have a good evening, have a good day, have a good morning, everything. And see you soon in Espen, maybe. Thank you very much.
Thank you,
Bye-bye.
Jean-Jacques.
Thanks. Bye-bye.